Hello everyone, welcome back to the series of discussion of the mind maps using the MediStudy Go's Oral Pathology Mind Map books. Keep this book close to you. I am Dr. Srikanth, one of the authors of this particular mind map session, and today we are going to look at odontogenic keratocyst. This is one of the most recurrent odontogenic cysts, and we need to understand the various philosophies involved in this so that you can understand why it behaves like that. So in general, as the name suggests, odontogenic keratocyst, the name says that it contains keratin. And keratin is a material which is the end product of a differentiation of the epithelial cells. So basically it can arise from any of the epithelial cells. But since it's odontogenic in origin, the characteristic feature is the ameloblast-like tall columnar cells, which is seen as a basal cell palisading in this particular cyst. The cyst is either a uni or a multicystic intraosseous tumor originating from the dental lamina and its remnants, but it can also arise from the basal cells or the basal cell hamartias, what we call it. So let's have a look at what causes this particular entity. The pathogenesis mainly involves the mutation of a gene called as Sonic Hedgehog. So basically what we are looking at is dental lamina or the basal cells, they start budding into the connective tissue. So you can see this, the dental lamina, that is the cell rests of serrae, are budding into the connective tissue. Similarly, the superficial epithelium is showing this kind of budding. Each of these cells contain a gene on the surface called as the patch gene, and you have a smoothened gene which is attached to it. And you know this guy, Sonic the Hedgehog. This guy kind of runs and comes, touches and stimulates the patch gene, and the smoothened gene gets released, goes into the nucleus and causes the cells to proliferate. Now, why did this proliferation take place? It took place because the Sonic Hedgehog gene came and bound to the patch gene. What if the patch gene cannot bind to the Sonic Hedgehog? So even without the presence of Sonic Hedgehog, that is, Sonic Hedgehog need not come here and stimulate it. Without that itself, the patch gene is not able to hold on to this smoothened gene, goes into the cytoplasm and stimulates the cell proliferation, which is in an uncontrolled manner, leading to excessive proliferation of that particular entity, leading to excessive proliferation of the cells. So that's what is seen very clearly in the mind map here. So the controlled release of smoothened gene is not taking place because of the patch gene mutation. This uncontrolled growth leads to proliferation of the epithelium. The epithelium proliferates in such a way that you will have some daughter cysts going inside the connective tissue. So let's have a look at the name. Why is it called OKC? It's called OKC because it is containing keratin, odontogenic origin, keratin producing cyst. So odontogenic keratocyst. Usually it is parakeratin, but orthokeratin can also exist. Clinically, usually there will be a swelling without pain. Expansion of the buccal cortical plate is seen only in 30% of the cases. And the reason is that it tends to spread in the medullary spaces. You will find that the lesion is spreading, almost going on to the entire side of the mandible, like you see here, without much of the buccal cortical plate expansion. Usually seen in the second and the third decade of age, with a slight predilection in the males, and posterior body of the ramus of the mandible is having predominance in this particular entity. Usually asymptomatic, and you can see in this case the cyst is almost involving the entire mandible. There will be displacement of teeth like you see over here, and there is a syndrome called as the Gorlin Goltz syndrome. We'll be talking about it in the end of the video. The characteristic radiological feature is this scalloping that you note, and you can see multiple proliferating lesions on the skin surface also, which is nothing but the basal cell carcinoma proliferation on the skin surface. Radiologically, you have this characteristic multilocular radiolucency, which has the scalloped appearance, and it kind of avoids the root apices, but it can also displace the same. And radiologically, there are 5 different types given by Main in 1970. The 5 different types given by Main are as follows. The first one is called as a replacemental. It is called replacemental because the tooth doesn't exist in that particular region. The second type is called envelopmental, in which you can see this tooth is enveloped completely by the cyst. This is called as the envelopmental style. The third type is extraneous, which is not there in a tooth-bearing area, and it is going in a ramus region, and usually it is originating from the basal cell hamartias. Collateral is the one which is occurring in between the two teeth. We are not sure what is originating this particular entity. It can be basal cells, or it can also be the cell rests of serrae which are present. The fifth type is a unique entity called as the follicular variant. In this particular type, there is a tooth. Now let's imagine a tooth like this, and then the tooth has a reduced enamel epithelium sitting on top of it like this. And we will have a cyst, odontogenic keratocyst, present on top. When this tooth erupts into it, the lining joins with it and gives rise to an appearance as though it is a dentigerous cyst. Let's understand that with an animation. So we have a odontogenic keratocyst which has developed. Underneath that, let's put a tooth which is going to erupt into this particular cyst. As the tooth erupts into the cyst, it merges with the cyst in such a way that you cannot differentiate between the reduced enamel epithelium and the odontogenic keratocyst. So basically, it looks as though it is a dentigerous cyst configuration of an OKC. So hence the name follicular variant of odontogenic keratocyst. So let's have a look at what are the various radiological characters. So basically, we see a scalloped appearance. Anterior-posteriorly can be multilocular. And since the collateral variant is in between the two teeth, we can have a differential diagnosis of lateral periodontal cyst. The follicular variant can give you a differential diagnosis of dentigerous cyst. So let's have a look at the histology of this particular entity. Histologically, this cyst has characteristic features. The first feature is that grossly, the cyst kind of comes out of the particular bone very easily. And when you see it under a microscope, it has this characteristic convoluted pattern. That means it twists and turns and convolutes. You can continue to see the convolution on the right side here. Apart from these, it can also have a very dense connective tissue, collagen bundles here, and which lacks inflammatory cells. It doesn't have much of an inflammatory cell. When you look at the epithelial lining, you will find some characteristic findings. Number one, you have the basal cells palisaded with maximum of 5 to 6 cell thick lining. Second, you will see a surface corrugation. You can see that the surface is not a straight line but corrugated in appearance. And then you will have these basal cells which are nicely palisaded, tall columnar cells, like a tombstone-like pattern. And it is predominantly a parakeratin. You can see some flakes of parakeratin coming out also. So basically, the 4 important findings are 4 to 10 cell thick, parakeratinized lining with surface corrugation and basal cell palisading. Now, these palisaded tombstone-like pattern, which is available, do not connect to the connective tissue very firmly. Hence, you can have a separation of the epithelial cyst lining from the basal connective tissue. And this separation is one of the reasons of high chances of recurrence. And like how we see the moon, which is our satellite, revolves around the earth, we do find some satellite cysts. So this is the main cyst lining, and you will have this satellite cyst present in the connective tissue. These satellite cysts are also called as the daughter cysts, which are usually left out during the surgery enucleation. It is no fault of the surgeon. It is because of the entity of the cyst which causes the removal of that impossibility of removal of that particular daughter cyst. And these satellite cysts can be 1 to multiple in number and will be a reason for recurrence. So in summary, the lumen is filled with keratinaceous debris, connective tissue is mature and no inflammatory cells. The epithelium shows a convoluted lining, 4 to 10 cell thick, surface corrugation, no rete ridges leading to a weak junction, separation of the epithelium, basal cells are palisaded, and you find daughter cysts. The odontogenic keratocyst enlarges very rapidly. So there are reasons for enlargement. You can divide the reasons into 3 regions. One is the lumen, one is the epithelium, and one is the connective tissue. The first 2 is the luminal changes. There is increase in osmotic hydrostatic pressure and osmolality, which leads to the enlargement of the cyst. The second component, the mitotic activity, is from the epithelial region. The connective tissue shows 4 important activities because of which the cyst enlarges. Number 1, it has special enzyme called as leucine aminopeptidase, which increases the resorptive activity of the bone, including the presence of glycosaminoglycans that makes it like a gel, and it invades into the connective tissue as well as the bone trabeculae. The collagenolytic activity of the cell wall, because of the intramural proliferation of the epithelium, can also give rise to this kind of a growth pattern. So the main characteristic features you should be able to draw would be the parakeratinized lining epithelium, tombstone appearance, separation of the epithelium, connective tissue capsule which does not contain inflammatory cells, and the presence of a satellite cyst. So the last component which we need to remember is the syndromes. The most common syndrome is also renamed as nevoid basal cell carcinoma bifid rib syndrome. And this syndrome is mainly because of the patch gene mutation that you see. Patch gene mutation gives rise to this particular syndromic activity. So the syndrome mainly is an autosomal dominant variant, and 1 in 60,000 patients show this case. And you see multiple basal cell carcinomas, odontogenic keratocysts, bifid rib, frontal bossing, ocular hypotaylorism, and medulloblastoma may also be seen along with palmar-plantar pits. So you can remember this individual: hypertaylorism, too much distance between the eyes, very flat nasal bridge, calcification of the falx cerebri, multiple basal cell carcinomas seen in the sun-exposed area, along with the presence of multiple odontogenic keratocysts. So in brief, we have a mind map. We understood the various modalities of this origin of this particular cyst. What are the various radiographic features, clinical features, and the treatment mainly involves the enucleation followed by a chemical cauterization. Since a lot of daughter cysts exist, they usually pack it with carnoy solution so that that particular daughter cysts are not proliferative anymore. So that gives you a brief about the odontogenic keratocysts. So like and share the videos and subscribe to MediStudy Go's app. You will be able to find out multiple mind maps, notes and videos, and also flashcards. So let's have a look at a few questions over here. What are the key histological features of odontogenic keratocysts? So you already know the various histological features. So let's have a look at that in the app. How does it show? It basically puts the picture of the mind map and gives you the brief about what are the various patterns that you see. Let's answer an MCQ. Which statement regarding an odontogenic keratocyst is correct? It has negligible recurrence. No, it has a very high rate of recurrence, and we gave you the reasons of recurrence. It's commonly associated with calcifications. Not exactly. It shows aggressive behavior with high recurrence rate. Very true. It shows an aggressive behavior because it goes in between the medullary spaces. It always presents as a multilocular lesion, which is wrong because we find unilocular radiolucencies also. So the correct answer here is C. So that finishes with the video, today's video of odontogenic keratocysts using the mind map. Happy learning. Continue. Be back with the next odontogenic cyst.